Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Barriers to Immediate Reconstruction in the Canadian Universal Healthcare System by Tony Zong et al. My name is Stephen Edge, and I am the Director of the Baptist Cancer Center in Memphis, Tennessee, and Adjunct Professor of Surgery at the Vanderbilt University School of Medicine. My oncologic specialty is surgical oncology. Mastectomy continues to be a widely used treatment for breast cancer. It is often necessary because of the anatomic extent of the cancer or because of genetic predisposition to a second cancer. In addition, some women select mastectomy because of perceived advantages and peace of mind. Recent data show that the use of breast conservation may be dropping, with a marked uptick in the use of therapeutic and prophylactic mastectomy. One factor contributing to the acceptance of mastectomy is the option to have breast reconstruction at the same time as the therapeutic mastectomy. Compared to delayed reconstruction, immediate reconstruction provides equivalent or better cosmetic outcome and no detrimental impact on cancer outcome. The combination of mastectomy with immediate breast reconstruction provides women an alternative that provides most with a satisfactory result and good quality of life. The use of immediate breast reconstruction varies widely. Certainly, cancer stage is a major determinant, with providers reluctant to offer this with advanced stage cancers where radiation is required and the risk of local recurrence high. However, beyond stage, the use of immediate reconstruction varies in relation to patient factors, socioeconomic, education, and insurance status, and the availability of plastic surgeons. To identify factors associated with the use of immediate breast reconstruction, Zong and colleagues from the University of Toronto examined the use of immediate reconstruction among women treated by mastectomy in the province of Ontario from 2002 to 2012. All women in the province have payment coverage for full medical care through the Universal Healthcare System. This study, therefore, was able to examine utilization of immediate breast reconstruction without the variation caused by differences in insurance coverage. The nature of the Canadian system also allows remarkably robust population information enhanced by the ability to link multiple administrative data sources. The study includes women undergoing prophylactic mastectomy and those treated for cancer. The relative rate of immediate breast reconstruction increased by 44%, with an increase of 79% with prophylactic mastectomy and in situ cancer. Women living in high-income neighborhoods were more likely to have immediate reconstruction, while recent immigrants to Canada were less likely to do so. In addition, women having mastectomy at teaching hospitals and at hospitals with 2 or more plastic surgeons doing reconstructions were more likely to undergo immediate reconstruction. Those having immediate reconstruction tended to live closer to high-volume reconstruction hospitals and traveled further from home for surgery than those who did not. The trends identified by Zong mirror those seen in the United States. A number of recent studies show an increase in use of immediate breast reconstruction in the last decade in the U.S. In addition, they also show that patient income, education, insurance status, race, and ethnicity are factors affecting use of reconstruction. Similarly, reconstruction rates were higher in teaching hospitals. Like Ontario, American studies show an increasing use of implant techniques in place of autologous tissue reconstruction. However, the absolute rates of reconstruction are quite different between Ontario and the United States. Overall, Zong reports that 8% of women with invasive breast cancer had immediate reconstruction. This rate was 11% for those with stage 1 cancer, 5% with stage 2, and 2% for stage 3. It is hard to find a study with exactly comparable populations. However, recent American series show markedly higher rates of immediate reconstruction. Jagsy et al. Reported in the JCO in March 2014 that among an insured population, 63% had immediate reconstruction in 2007. Using the National Inpatient Survey to identify all mastectomies, for cancer and otherwise, that included women of all ages, the rate of immediate reconstruction rose from 21% to 38% between 1998 and 2008. Another study using the National Inpatient Survey, limited to those with cancer, by Yang and colleagues, showed high rates of reconstruction among younger and insured women. This and other studies show much lower rates in older women, between 5 and 10%. It is, of course, intuitive that the availability of reconstructive surgeons influences the use of immediate reconstruction. Zong found that just over 50% of hospitals that performed mastectomy in Ontario did no reconstructions, a fact they used as a proxy for no plastic surgeon. About 1/4 of all mastectomies in the province were performed at these hospitals. 2 American studies show the same relationship. Jagsy's recent paper in the JCO also shows a relationship between rate of immediate reconstruction and plastic surgeon availability measured as number of surgeons per 100,000 population. Greenberg et al. Showed that within the National Comprehensive Cancer Network hospitals, the rate of reconstruction correlated with the number of plastic surgeons at the center, though I must add that those with many plastic surgeons are specifically known for these services and attract patients seeking that service, thereby skewing reconstruction rates. These findings raise a serious practice concern that is equally relevant in Canada and elsewhere. The use of immediate breast reconstruction is fully accepted as safe from a cancer standpoint and a strong option for women of all ages. The personal benefit has been demonstrated repeatedly for women who choose to do it. Of course, many women will choose to forego reconstruction because of medical reasons, cancer or comorbid conditions such as active smoking, or because of personal choice. However, reconstruction should be offered to all who meet reasonable standards for its use. The problem lies in that breast cancer surgery is done in virtually every acute care hospital, large and small, where there is a general surgery practice. But many of those communities have no plastic surgeon performing immediate reconstruction. This was over 50% of hospitals in Ontario. The same is probably true in the United States, though I cannot find this figure in the literature. Zong characterizes this as a fundamental challenge to the central values of universal coverage, even within this system where there are inequities in access that create barriers to high-quality care. In the U.S. and Canada, plastic surgeons are concentrated in larger hospitals and in larger metropolitan areas. It is unrealistic to think that we can mandate better distribution of plastic services. The only solution to offering immediate reconstruction may be to have the operations done in a setting where it is an option. This begs the question of how a woman is to be appropriately counseled on its benefits and risks if reconstruction is not performed where she is treated. The local surgeon may certainly provide a balanced discussion and may even offer referral to another surgeon working at a hospital with experienced reconstructive surgeons. However, Despite all best intentions, it is almost too much to believe that there will not be other forces that act on the breast surgeon and the hospital that will limit these discussions and referrals. I am certainly realistic. Regionalization of breast surgery is unlikely to be a viable option in the current environment. We readily accept regionalization for high-risk procedures such as bone marrow transplant, pancreas resection, and heart surgery. However, given the low risk of breast surgery, coupled with distances, patient convenience, and the large number of people involved, regionalization itself may be a barrier to quality in breast cancer care if it stops women from receiving treatment. New models of shared care, decision support, and long-distance video counseling may be needed to assure women are fully aware of their options. At the individual level, patients deserve to understand the real value of treatment options. And the burden must be placed on treating physicians to inform patients when those options are not available at a local institution. Collectively, we also need to recognize the inherent barriers and inequities that the organizational and financial incentives of our healthcare system place on our patients. This concludes this podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.